Awesome. So that's right. I'm Annie. I'm a GI fellow, and I'm a former GICU. One of the highlights of my residency being working with Rini as her senior in the MICU when she was an intern. Good times. And I'm going to talk today about alcohol-associated hepatitis. And I first want to call out the change in the nomenclature. So we used to refer to this as alcoholic hepatitis, and to try to use less stigmatizing language, we are now calling it alcohol-associated hepatitis. You will still hear me call it ALC-HEP at times, just for short. So my objectives, so I want by the end of this talk for you to be able to recognize key features of the clinical presentation of alcohol-associated hepatitis, distinguish between alcohol-associated hepatitis and decompensated cirrhosis, initiate appropriate treatment for ALC-HEP, name one pharmacologic treatment for alcohol use disorder that is safe in patients with liver disease, and articulate what patients should be considered for transplant for ALC-HEP. There will be some questions, and I'm going to ask actually that I'm going to give you a couple seconds here in a minute to get a piece of paper or a notes app out to jot down your answer to these questions. I know not everyone is going to feel comfortable answering on chat or by unmuting. And so in order to kind of help with your own engagement in the material and your own learning, I would really encourage you to humor me on this exercise and answer the question for yourself by truly writing it out or typing it out. As I was a clinician educator resident within that track, so I know that in terms of adult learning, we do not learn well passively by just looking at slides. You have to participate with the information. So I really encourage you to do this for your learning. And I really appreciate your engagement and your paying attention today. I worked hard on this presentation, so thank you for giving me your time. Now, what is alcohol-associated hepatitis? So that we're on the same page about what we're talking about. This is this syndrome of acute onset of symptomatic severe liver injury or liver failure in a patient who's been drinking for a significant amount of alcohol over a long period of time. Now, why should we care about alcohol-associated hepatitis? So I want to preface this with these patients have a high mortality. These patients come in incredibly sick, and it's important that we can diagnose it and guide appropriate treatment early to try to give them the best survival possible. So severe alcohol-associated hepatitis has a 20 to 50% mortality within 3 months. And even just moderate alcohol-associated hepatitis has a 20% mortality within a year. So we will talk more about what treatments and solutions we have for them, but spoiler alert, there are not many and they do not often work well. So we have to do a better job at preventing people from actually getting alcohol-associated hepatitis. And early diagnosis, when we actually can help with alcohol cessation and preventing progression of this disease, is key. Now, I also want to preface this talk talking about alcohol and the trends in alcohol use in our country, which are increasing, and particularly were during the COVID-19 pandemic. So people were home, people had lost their jobs, alcohol sales went through the roof, and alcohol-related hepatitis hospitalizations increased by 50%, and the population is getting younger and the trends are looking like more people who are female affected over males, and they're presenting with higher MELDs and more severe disease. And 40% of liver transplant listings during the pandemic were for alcohol-related liver disease, which is more than for Hep C and MASLD combined. And so I want to stress that we see, particularly at Montlake, we see a lot of rare liver diseases. We see a lot of different liver diseases. But in hepatology, this is still the main thing that we deal with is alcohol-related liver disease. It is still of enemy number one in trying to prevent liver disease in our country. So when we think typically about the way alcohol-related liver disease progresses, what is the typical natural history? We usually start over here with alcohol-related steatosis. So alcohol use over time causing cholesterol accumulation in the liver. And usually we just see that on, say, an ultrasound that people might get for abdominal pain or something like that. But usually these people are actually asymptomatic, maybe have a little bit of an AST elevation. Then over time, with continued alcohol exposure, you can get some inflammation of that fat in the liver. And that is called alcohol-related steatohepatitis. So these patients will start to have a recognizable, AST greater than ALT on their labs. They're starting to have that inflammation of their liver cells. And then further over time, as we know in any organ of the body, long-term inflammation leads to scarring or fibrosis. And that is the end stage of that liver fibrosis is alcohol-related cirrhosis. So most people over a course of the decades of drinking alcohol on a regular basis will have this progression might have this progression to cirrhosis. But then we have this certain population that seems to leave this usual progression and get a acute onset of symptomatic liver injury that is alcohol-associated hepatitis. And it seems to be able to come at any point in this continuum, that some people will just leave the trajectory and get a much more severe phenotype of disease. Now, what is happening on a pathophysiological level in this? So this is the hepatocyte here in pink. And as we see that we have alcohol dehydrogenase, that ADH within the hepatocyte that then metabolizes ethanol into acetaldehyde. And acetaldehyde is really the bad actor in alcohol's effect on our bodies in general. It's what makes you feel hungover. And it's also what within the hepatocyte causes the creation of ROIs, a reactive oxygen species, which then causes lipid perioxidation, so that fat inflammation within the liver cell, and then hepatocyte injury. And what we see is that inflammation causes hepatocellular injury, and then hepatocellular injury then exacerbates inflammation. And around we go. It's like a bad feedback loop that these patients can get into. And gut bacterial translocation makes that inflammation even worse. People with alcohol-related hepatitis have basically leaky gut. They have more bacteria coming from their gut into their bloodstream, or bacteria-related proteins that then exacerbate this inflammatory response. And from inflammation, as we talked about, you can get fibrosis. We can also get impaired hepatocyte regeneration. So one of the most amazing things about the liver is that it can regenerate, and the liver in this situation will try to regenerate. It's trying to make new hepatocytes, but in this inflammatory, toxic milieu, it doesn't create very functional hepatocytes. So you get this sort of scarred and also congested liver of liver cells that are not working appropriately. And that can then give you synthetic dysfunction. So that is the poor function of the liver, which usually is in not making clotting cells. So having an elevated INR and an elevated bilirubin. And then from blood not being able to push its way through a congested, inflamed liver, you get portal hypertension, and you can see acute onset of ascites, edema, and varices. So now I want to talk about a case of a 49-year-old patient who is a history of depression, gastric bypass surgery, and alcohol use disorder in early remission, presenting to the ER with weakness and falls over the past week. This patient quit drinking 2 weeks before their presentation. On exam, they have jaundice, lower extremity edema, ascites, and they do not have ascites, and they do not have asterixis. Their lab profile, they have an AST of 331, an ALT of 117, an ALK Phos of 167, bilirubin of 22, and an INR of 1.7. So now is the time to get out your piece of paper or your notes app and tell me and write down. No one has to say anything in the chat or say anything out loud yet. So just say to yourself at home, what is on your differential for this presentation and what workup do you want to order? And I'll give you like 30 seconds. Okay. Now I would really appreciate anyone putting in the chat or unmuting to say what is on their differential and what they want to order. I'm going to put the chat up here. I know you guys can see it, but that's okay. Oh my gosh. Great. Alcohol-related hepatitis. Perfect. Decompensated cirrhosis. Thank you, Sienna. Sienna Lee will someday be giving this talk, by the way. Hepatitis C or hepatitis B. Yes, great. So we want to make sure to be on the lookout for that. Portal vein thrombosis. Thank you so much, Shaylee, for participating. Dilly, Clinton, very nice. Dilly stands for drug-induced liver injury. Liz Tower, great. Alka, cholestatic liver injury, cholangitis, choledochondrocytis, amazing. Anything that you guys want to throw out there that you would want to order for initially to rule any of these things out or investigate any of these things? Great. Thank you, Laura, for right upper quadrant ultrasound. Sounds great. PT. Hep serology is excellent. Sure, yes. Direct and indirect bilirubin. Yeah. And thinking about kind of cholestatic causes. Excellent. Okay. Thank you everyone so much for participating. So I think what many of you identified was this is a good, illness script or a good case to illustrate alcohol-related hepatitis due to several of the key clinical features that we find. And those being this acute onset of jaundice. So people noticing that their eyes are yellow, their skin is yellow. They will also often have malaise, and that's because we have this massive inflammatory response, that someone's immune system is really revved up, so they feel sick, they feel tired, they feel nauseated. They might have ascites or edema, those manifestations of acute portal hypertension, and they might, due to a coagulopathy, have some more bleeding or bruising that they have noticed at home. Now, there's a big severity in presentation. So I think a lot of people we have taken care of in the hospital who we've had exposure to look like this man over here. They are incredibly jaundiced. They have a very, very high bilirubin, and they are very sick. But people can have a much milder phenotype. And that brings us to talking about what the diagnostic criteria are for alcohol-related hepatitis. So the onset of jaundice within 8 weeks, that is that acute component. They should be drinking more than 3 drinks a day for people born female, or more than 4 drinks a day for people born male for at least 6 months of time. So this is this high alcohol exposure in over a long period of time. So 18-year-olds who go to college and start binge drinking and do that for 1 or 2 years, they are not the phenotype of people who get alcohol-related hepatitis. You need to have an extended over years and years of a high exposure to alcohol. They should have less than 60 days of abstinence. So people who have been sober for years will not come in with this. But one thing is our patient in this case is very typical in that people may have stopped drinking weeks to a month to 2 months before they present. And that can still be acute alcohol-related hepatitis. Often people start feeling sick at home and they stop drinking alcohol, and then they don't feel better after they've stopped drinking alcohol and they ultimately present for care. So just because they didn't drink alcohol yesterday doesn't mean that this couldn't be acute alcohol-related hepatitis. Their serum bilirubin should be greater than 3. Again, coming back to this hallmark of jaundice and hyperbilirubinemia, but it only has to be 3 or greater, meaning that people can have a much more mild phenotype of disease only with a bilirubin of 3 or 4 and meet the diagnostic criteria. They should have an AST and ALT ratio of more than 1.5, so that classic AST greater than ALT that we all know, but neither of them should be greater than 400. So if liver tests are getting up into the 500s, up into the thousands, then we should think about, is there something else going on, or is there more than one thing going on? So we do want to rule out other causes of liver injury. That you all did a nice differential of what we would be thinking about, because often people have another cause of their liver disease and they drink alcohol, and we don't want to miss those other causes. So the workup should include an abdominal ultrasound with the Doppler. Someone pointed out portal vein thrombosis. What?
Just a question in the chat. Is the sex differentiation based on expected weight difference or related to hormone?
Oh, yeah. Thank you, Anna. So it's actually sex-related differences in the amount of alcohol dehydrogenase enzymes or other enzymes that help you process alcohol and its metabolites in the body, that people born female have been shown to not have as many of those enzymes to be able to help us process it. So basically, we just don't have as efficient of alcohol metabolism. I don't think that it's necessarily weight-based. Okay. So abdominal ultrasound with Doppler, and that's to look for that portal vein thrombosis. One thing I want to point out here is that we often run into is if someone has had a CT with contrast of their abdomen pelvis, they might not actually need an ultrasound with Doppler because they often get really nice venous like vessel imaging with the CT with contrast. So you can probably not get that right away if they've already had a CT with contrast. Then acute viral hepatitis panel, so that's that Hep A IgM, Hep B serologies that Liz brought up, and then, but also getting a Hep B DNA PCR because the serologies can lag in an acute Hep B infection, Hep C antibodies and Hep C PCR, again, because the serologies can lag. Acetaminophen level is important because it's a do not miss and people can die very quickly from Tylenol overdose. And then the ANA, anti-smooth muscle, and antimitochondrial muscle antibody and IgG. These are, again, just like important to rule out that they don't have this as another underlying hit to their liver. The serologies can take a while to come back, so I encourage you to send them early. And then ceruloplasmin is to rule out Wilson's disease, which can also cause acute liver injury and acute liver failure. Okay, so who gets alcohol-associated hepatitis? Now, the patient in this case highlighted several of the important risk factors. So heavy drinking over years that I've highlighted a couple times. And the only other thing I want to say is that there's not one pattern of alcohol exposure that is known to be a definite risk factor or like to definitely give you alcohol-related hepatitis. Some people are do participate in like binge drinking and over a very long period of time. Some people can just have 2 cocktails a night over years and they can get alcohol-related hepatitis. So it can be a variety of different drinking patterns. The average age is usually 40 to 60 years old, more in patients born female, as we've discussed. And then Hispanic ethnicity is associated with this, and this is most likely due to a higher prevalence of the PNAPL3 gene in this population. And that is associated with many liver diseases, not just alcohol-related hepatitis. A history of bariatric surgery is very important. We have time and time again see particularly women who get bariatric surgery when now their alcohol tolerance is much low. It really changes your metabolism of alcohol and makes you much more sensitive to the effects of alcohol. And then underlying MASLD, so this is metabolic dysfunction associated steatotic liver disease. Once you have one hit to your liver, one reason to have some steatosis and inflammation of the liver, adding another hit like alcohol is can make it so that you have further decompensation quicker. Now, one thing I think is important, and we look at these risk factors, many of these, except for that, the average age, many of these are actually risk factors for any alcohol-related liver disease or alcohol-related cirrhosis. So these don't necessarily predict who is going to fly off into alcohol-related hepatitis physiology. And so that would be one takeaway is it's still largely unknown why some people have this slow progression of alcohol-associated liver disease and some people get ALCHEP. Okay, so we're back to some questions. So what are the clinical signs and symptoms that can distinguish alcohol-associated hepatitis from decompensated cirrhosis, a situation we get into very often? So I'm going to first have you not put anything in the chat and just write down for yourself at home what your answer to this question would be. I'm going to give you 30 seconds. Okay, great. Can some people please contribute in the chat or by unmuting with what their answer would be to this question? Austin Chen, less of Less of the vibes. No esophageal varices, no ascites, no spider angiomata. Yes, vibes being referring to volume, infection, bleeding, encephalopathy, and screening is like a framework for how to think about patients with liver disease in general. Thank you, Austin. Anybody else? Sources associated with synthetic dysfunction, yes, low platelets, elevated PT, low albumin. Yes, great. Yeah. So those being more associated with kind of a chronic dysfunction of the liver and more of a fibrosis than from an acute injury. Yes, that's definitely right. Previous presentations, sure. And sort of talking about chronicity and acutely and significantly elevated LFTs. Yeah, because kind of if you have more scarring of the liver, often you don't have as many hepatocytes left to kind of give you a more exaggerated liver test elevations, rapidity of jaundice onset and symptoms. And yeah, that is really key. Alcohol hepatitis can have tender hepatomegaly on exam. Yes, that's correct, Sophia. And Will Schieflane says, is there any difference in the liver size in large liver shrunken and cirrhosis? And the answer is yes. So I'm going to move on to this, talk about these differences. So alcohol-associated hepatitis often has a stigmata of active inflammation. So they will have that tender right upper quadrant and they will have hepatomegaly. They will show other evidence of inflammation like fever and tachycardia. These patients are often just like constantly in a SIRS state. And they can have nausea and vomiting and more of that kind of in that acute time frame. And the hyperbilirubinemia often be much more marked in patients with acute alcohol-associated hepatitis. And then for decompensated cirrhosis, I'm glad that someone brought up that they will have spider angiomata, palmar erythema, these physical exam findings that we associate with a chronic liver disease and have more marked synthetic dysfunction like low platelets, elevated INR, and low albumin. Okay, so this is another question that I'm not even going to give you any time to think about. So just contribute in the chat. What is the most important treatment for patients with alcohol-related hepatitis? Okay, I'm getting a lot of steroids here. Getting a lot of steroids. Anyone have any other ideas? Alcohol cessation. That's right, Laura and Will and Liz. Abstinence from alcohol is the most important treatment for anyone along any of the continuum of mild alcohol-related hepatitis to severe alcohol-related hepatitis. I think a lot of people think of steroids right off the bat, but I want to change our framework to as soon as you meet this person, thinking, how can I help support this patient in never drinking alcohol again? Because that is truly the most important treatment that we can offer them. So what treatment for alcohol use disorder could you offer the patient in our case who are admitted in the ER? They have recently stopped drinking alcohol. They have a moderate alcohol-related hepatitis. What kind of treatments can you offer them? And I'll give you, again, let's not comment in the chat yet. Let's everybody think and write down to yourself at home for the next 30 seconds. What is the kind of treatment that you can offer them? Okay. What do we got? Who has an idea of what alcohol use disorder treatment we could offer this patient? Naltrexone, excellent. Naltrexone, topiramate, Sienna, awesome. Psychotherapy plus acamprosate, excellent. ART, aka alcohol replacement therapy, NA beverages. Wouldn't there is, you know what? Well, no one has done the study on NA beverages yet. Gabapentin, topiramate, get expert involved. Yes, expert being yes, screening, brief intervention, and referral to treatment. Excellent. Okay. So I'm glad people brought up both pharmacologic and non-pharmacologic treatment. So of course, involving behavioral health and an addiction medicine specialist. There's not one behavioral intervention that is shown to be superior, but I will say studies that have shown an intervention where both the hepatologist or the medical team is working with the addiction medicine specialist when they have kind of a hybrid model for addressing this patient's addiction, that has shown to be superior than just addiction medicine alone. But so getting addiction medicine, but I think we have an addiction consult service at every single hospital where we work now. And then pharmacotherapy that is safe in liver injury. So acamprosate does not have any hepatic metabolism. So it is a nice first choice and we use it a lot. But it is renally cleared. So if patients are going into renal failure, then this would not be a great choice. It is TID dosing, which can be somewhat hard for people to stick to. And it can cause diarrhea, but that often goes away over time. It's overall very well tolerated and can help with cravings and with some of the symptoms of alcohol withdrawal. Baclofen has also been studied in people with liver injury and is safe. It has a little bit of a central acting effect. So if people are getting sleepy or people have hepatic encephalopathy, not as good a choice. Naltrexone has come up and it does have hepatic metabolism. And so there have been some like black box warnings around people with liver disease and naltrexone. But many people who work in the field will say they have not seen really bad, increase in liver injury with naltrexone, and that those are really more rare, and that honestly, keeping someone from drinking alcohol is so much more of a benefit than the potential risk of additional liver injury from naltrexone, that if this is the best option for them, it's once daily dosing, it doesn't have as many central effects. You can even have a long-acting injectable formulation. If this is truly the best choice for them, then I would still consider it. Gabapentin, of course, often is most effective in those higher doses, that it can take time to get people up to those higher doses of gabapentin. And then topiramate, as long as the patient doesn't have hepatic encephalopathy. The only one that's really not indicated is disulfiram because it has more of a hepatic metabolism. So all of these can be started in the ER. They can be started in the hospital. They can be started in clinic. You do not necessarily need an addiction medicine specialist to guide you. I really encourage you to start with these medications for your patients, and probably guide some of your attendings and hold their hands and being able to encourage them to prescribe it as well. So when we're talking about severe alcohol-related hepatitis, we know that there is a benefit to alcohol cessation. Then we should really need to look for and treat infections. Half of people who die from severe alcohol-related hepatitis will die of an infection. That immune response really is like a distraction for the immune system. So it's focusing all of its efforts in the wrong place and not focusing its efforts on actually fighting infections in the body. And so these people are immunosuppressed. They get infections and they die of them. So when these people come in, doing a good physical exam, looking at all of their skin, making sure they do not have any kind of cellulitis or a toe infection, looking in their mouth, or asking about whether or not they have any symptoms of a tooth abscess. And then getting blood cultures, urine cultures, chest x-ray, and for the love of all that is holy, get a paracentesis if they have ascites. Any person being admitted to the hospital with ascites needs a diagnostic paracentesis. Then an early focus on nutrition. Now, nutrition is key. So patients who have alcohol-related hepatitis have altered caloric metabolism. They're using up a lot of their nutritional efforts on metabolizing alcohol, and they're not metabolizing food normally. And so they need a lot of sustained intake of calories. They're incredibly at risk for developing malnutrition, and malnutrition is associated with an increased rate of sepsis and mortality. So we need to talk to patients about calories and focusing on protein. If we look at this picture over here of all these different protein sources, I talk to patients about eating meat, eating nuts, eating beans, eating cheese. Eggs are one of the few things that you can order in the hospital that are actually pretty palatable. And so yogurt, Greek yogurt can be easier for people to tolerate and a great source of protein. And then I want to encourage a low threshold for introducing the idea of an NG tube. Even telling your patient as you're admitting them that you're going to be paying very close attention to how much they're eating. And if they are not meeting their caloric needs, we're going to recommend an NG tube. And I know when I'm on the hepatology service, I probably hounded all of you about this and trying to focus on more on the nutrition of our liver patients. This is a kind of a line I usually put in all my assessment and plans for my recommendations. I say I recommend nutrition consult and a high protein, high calorie diet. It's okay to liberalize their sodium restriction if it is limiting them from eating things like meat and cheese. They should not be eating potato chips, but if it's limiting how much they can actually eat that is palatable, then it's okay for them to have more salt. 3 ensures per day. Encourage bedtime snacks and eating overnight. Fasting is not helpful to patients with liver disease. They cannot mobilize calories from their liver like the rest of us overnight. And then a low threshold for NG tube if not meeting their caloric needs by mouth. I want to stop there. Are there any questions about this? Okay. I am going to put the chat away again, so I'll just have Will tell me if any questions come up. So this is a multiple choice question. If we have a poll that can come up, that'd be great. Or people, again, can just write it down at home. How do you decide what patients should get steroids for acute alcohol-related hepatitis? So you can just answer it at home or, oh, we have a poll. Fabulous. Okay, let's get the poll answers. Okay, C. So most people said the Madries, and some people said MELD, and a few people for Lirspor. Great. So the answer could be both C and D. We have classically used the Madries discriminant function, and the inputs into this calc, and you can just find this in MD Calc or by Googling it, but it only involves the prothrombin time or the INR and the bilirubin. And it has been well validated that patients with a Madries discriminant function of over 32 have a 30 to 50% mortality at 28 days. This is how we kind of diagnose someone as having severe alcohol-related hepatitis and who may benefit from steroids. People are now also using the MELD. It hasn't have as much validation for this indication, but the inputs are creatinine, bilirubin, INR, sodium, albumin, and sex at birth for that. That's for the MELD 3.0, which I encourage you to use moving forward. And it is time tested in predicting liver disease mortality for transplant, for cirrhosis. And so a lot of people kind of like this better and believe that it's a better illustration of someone's potential mortality. So our thoughts on steroids for severe alcohol-related hepatitis come from the STOP-AH trial from 2015. So this is a randomized controlled trial of prednisolone versus pentoxifylline versus placebo for severe AH. Now, pentoxifylline didn't show any benefit, so that's why probably a lot of people here have never heard of pentoxifylline. We do not use it typically for alcohol-related hepatitis. But what it showed here on this graph, you can see this is a survival curve. So the proportion surviving here on the y-axis, and then the x-axis is days since start of treatment. And so people who received prednisolone, you see that blue line is slightly higher. So it has slightly higher survival at 28 days than people who did not receive prednisolone. And that ended up not even being a significant difference, but it was notable at 28 days. Now, when you follow these people out for a year, so now if you look at the x-axis, this is days since start of treatment is going out all the way to 420. And these are every single arm of the study. It was a 2-by-2 study, so people got exposed to multiple treatments. But really what you can see is that all of the lines converge. So there was not a survival benefit of any of these treatment strategies at a year or even at 6 months. So the takeaway being that steroids have been shown to improve 30-day mortality, but not 6-month or greater mortality in patients with alcohol-related hepatitis. And this has been repeated actually several times since the STOP-AH trial to be true. Now, if you're going to try, 30 days is not nothing, and particularly for the patient involved, they will want as much time as you can give them. So we do use steroids even in acknowledging this data. And so if someone has a Madries discriminant function of greater than 32 or a MELD greater than 20, they can be considered for steroids, but then you should calculate the Lille score, which at 4 days and 7 days. 4 days is found to be equivalent to 7 days. Usually there's a difference in practice. I think if they respond by 4, you can do it at 4 days and then at 7 days if you'd like to. So the Leo score shows basically how has their bilirubin changed since they got steroids. And if their bilirubin decreases significantly, the Leo score will be favorable, meaning they are responding to steroids. This is working for them. So you can continue steroids. But if it's not working for them, then you should stop steroids. And so this is kind of a simple framework for how to think about it, but we should always think about contraindications to steroids before starting them. And that would include an active infection. Obviously, we don't want to hit them with high-dose steroids if they have an infection, if they have a significant AKI, if they have active GI bleeding, or if they have other diseases that you've detected in that initial workup, then they should not be given steroids. And if they meet criteria for steroids and they do not have contraindications, then you can use methylpred or prednisone. Methylpred is just what was used in the initial studies. Prednisone works fine too, and both of them are dosed at 40 milligrams per day for this indication. And then when you calculate their Lille score, if it indicates benefit, they should continue for a 4-week course, so that 28-day course of steroids. There's this question of adding N-acetylcysteine. So there have been studies that shown along with steroids, N-acetylcysteine can further improve that 30-day mortality. It still doesn't change their long-term mortality after 30 days. It is a lot of volume. So if people have a lot of ascites or edema, we usually don't use NAC, but if volume is not an issue, it is a great idea to add NAC. It has very few other side effects. If they're not steroid responsive, it's time to talk about a transplant evaluation or about palliative care. This is a flow sheet that will just be included in the slide. So if you download this slide deck later to have as your reference, this is just a nice flow sheet from the AASLD about how to assess someone with alcohol-related liver disease for whether they should get treatment or not. So here's a question. And I will say this is a little less amenable to polling, so you don't need to put a poll because there are more than one answer that could be correct. So why have transplant centers not traditionally offered liver transplant to patients with acute alcohol-related hepatitis? Does it not improve survival? Are they at a higher risk of relapsing on alcohol and then injuring their graft? Their liver function will improve with alcohol cessation, so livers should be given to patients with irreversible liver injury, or do they not meet the mandatory 3-month sobriety requirement for receiving a transplant? I'm going to let everyone think about this for like 20 seconds, and then we'll have you answer. Okay. Do people have thoughts on which answers might be correct? Two and four. Thank you so much, Sienna. Yeah, this is a tough one, I think, as is kind of illustrated by fewer people having an answer. Laura says maybe 3. And this is more kind of a think question about, many of the different kind of biases that we have about people who drink alcohol or about what should be possible here. And the answer is that it does definitely improve survival in alcohol-related hepatitis to offer transplant. There's some studies in the 80s that showed that people who could maintain their sobriety for 6 months were less likely to relapse, but that has largely been disproven, and they're at just as equal a risk of relapsing people if you have recent sobriety or not recent sobriety. And then many people will have an improvement in liver function with alcohol cessation. But the issue is that we're talking about a 30 to 50% mortality within 3 months. Most people just don't have time to see that benefit. They will die before their livers have been able to recover. And so there has been this mandatory 3-month or 6-month sobriety requirement for transplant that has been present in most centers for a long time. There is no national rules about how long someone has to be sober to get a transplant. This is purely transplant center based. You get to make your own rules for your transplant center. And even at UW, we had a 3-month sobriety requirement for a very long time. But then even despite some studies from 2011, this seminal study out of France that showed that early liver transplantation for acute alcohol-related hepatitis had a massive mortality benefit. So just to orient you to this graph, we again have survival on the Y and then months on the X-axis here. And they had 26 patients who underwent liver transplant for acute alcohol-related hepatitis and then 26 matched controls. And if you look at this lighter gray line at the top, you can see that at 1 year, patients who received a transplant had a 71% survival. And then patients who did not receive a transplant had a 23% survival. So that is a massive mortality benefit to offering transplant for this condition. And even so, I'd say it took us another decade after this before centers were really doing transplant for acute alcohol-related hepatitis. But we now have this great consortium of several different centers who are all doing transplant for acute alcohol-related hepatitis and pooling their outcomes to study this. And so this graphic shows that they had, an early transplantation of 147 patients, so no specific sobriety period. These patients would typically have a mortality of over 70% at 6 months. And with transplant at 1 year, the survival was 94%, and at 3 years, it was 84%. And by 3 years, 17% of patients who got a transplant had returned to some amount of alcohol use, but that was not necessarily heavy alcohol use. Some of it was just like sips or, twice a week kind of wine with dinner kind of alcohol use. So this does raise the question of how do we choose which patients we think are going to maintain their sobriety? If we've decided that previous period of sobriety, of just saying like people who've been sober for 3 months, that's the best predictor. If that has been disproven, then what is the best predictor of longer term sobriety? So the same consortium studied the patients who got liver transplants and made a predictive model to identify patients at lower risk of relapse. And so patients who had more than 10 drinks a day prior to their admission, or multiple failed attempts at alcohol rehab, or prior alcohol-related legal issues, or a history of other illicit substance use, those patients have a higher score. But if they have a score that is less than 5, that is a 95% negative predictive value for sustained alcohol use post-liver transplant. So mostly when we talk about what are the requirements for transplanting people for acute alcohol, it has to be to have a score on this scoring system of less than 5. Other predictive variables are if patients declined to participate in intensive outpatient therapy or had continual alcohol use while with knowledge of their liver disease. So this brings us to transplant for acute alcohol-related hepatitis at UW. So Montlake now has an early sobriety protocol established in 2022, and this is for patients with severe non-steroid responsive alcohol-related hepatitis. And 9 patients have been discussed at committee for this protocol specifically, and 5 were approved for transplant. 1 person actually improved and did not need transplant, could get delisted, and 4 patients have been transplanted. And 4 out of the 5 of those patients who were approved are engaged in intensive outpatient treatment, and 5 out of 5 have abstained from further drinking. Now, the takeaway I want you to really hone in on is that when you are working at Harborview or at other institutions within our area, you should refer your patients with severe non-steroid responsive alcohol-related hepatitis to UW for transplant consideration. I think too many people don't know that this protocol exists, and so are not able to advocate for their patients and give them this chance at a life-saving intervention. Now, I think though it's important to recognize that it is still incredibly selective who is actually being considered. It has to be your first episode of decompensation. You cannot have a history of failing substance use treatment before. The patient has to be coherent, so they can't have such severe encephalopathy that they can't be interviewed. They can't have any other substance use or use opioids or benzos chronically. They can't have any untreated psychiatric illness. They have to have social support and a willingness to abstain. And I think what's tough is a lot of these, like the nature of alcohol use disorder is that people are going to relapse, is that people are going to need multiple chances. And it's unfortunate that still within our protocol, it has to be your first exposure to your liver disease, the first time you have had a real problem with alcohol if you're going to be considered for transplant. And really that should all make us think that, transplant is not the answer for this. The answer is going to come in prevention and early identification so that we can keep people from getting to this point. So takeaways. Key feature of alcohol hepatitis is acute onset of jaundice, hyperbilirubinemia. Alcohol-related hepatitis has this inflammatory features, high bilirubin, hepatomegaly, abdominal pain, and cirrhosis is going to have more physical exam signs of chronic liver disease and evidence of synthetic dysfunction. Remember to please treat alcohol use disorder, and you can use pharmacologics for that, even in patients with liver disease. Acamprosate, gabapentin, baclofen, naltrexone are all safe for most patients with liver disease. You can consider steroids for a MADRS greater than 32 or a MELD greater than 20, as long as they don't have any contraindications. And transplant is a valid treatment option for patients with severe alcohol-related hepatitis that is unresponsive to steroid therapy. Thank you so much. I want to say a special thank you to Mui Lee. She's now an attending at Northwest. She is the one who passed along the information on the UW early sobriety protocol. And I want to say, if you love the liver, let's talk. If you think it's the best organ, I would love to talk to you. I'd love to get you more involved in the department or otherwise help you with any opportunities within hepatology. I'll take any questions. Oh, I see one here. Does it have to be their first episode of ALK-HEP or then they can to be considered a transplant candidate? Yes, it does have to be the first time they have ever been told that they have a liver disease. Kidneys are, oh, Duncan, get Q22. I have to say, the kidneys are really awesome. I have to say. All right. Awesome. I should yield the floor to Dr. Hussey.
Thank you. I think we'll take